Okay, I think we're live. Yay. I think we did it.
Yay.
So, Rebecca, it's so great to see you.
Good to see you too. Thank you for having me on here.
Of course, of course. How are you?
Good. Thank you. How are you?
Good. I'm good. I am good. I am so excited about what we're going to talk about today. I am going to see if I can. Oh, perfect. Okay. I can toggle my screen here. So, yeah, we are going to talk about behind the scenes for coaching and some of the things that we talk with people about on a regular basis. So I'm really excited to have this conversation. And for people that are joining us, please be sure to put your questions that you have in the. There should be a chat option for your questions. So we're gonna start out talking about some of the questions that we get super commonly in coaching and how we address them and how we answer them and that kind of thing. But also feel free to put your questions in the chat because we'll be looking at those also. Okay. So, Rebecca, we deal with a lot of people with very complex conditions, and there are rarely simple answers, right? So, let's share kind of some of the questions that we ask, the factors that we consider, and how we work through these challenges to help people move forward in the best possible way. Okay, we're going to start with an example question. Okay. So this person says, I'm 24 years old. I'm so exhausted. I can't get through my workday anymore. How can I get my energy back? So Rebecca, let's start with you, how you approach this.
Great. Thank you. Yeah. And this is a question we hear all the time in clinic, through online forums. In coaching, it's such a common issue. And I think the way that I like to approach questions, whenever someone asks me a question, I usually start by asking them a bunch more questions
Right.
because I think it's so important to see things in context. There are so many causes of fatigue, and especially in people who have joint hypermobility disorders, and all the different things that come along with it. There really are a lot of causes to consider and a lot of factors to consider. So with these conditions, I always try to look at the big picture and see like what else is going on. Particularly for fatigue, the first thing I ask about is sleep. So how are you sleeping? Do you get enough hours of sleep? Do you feel rested when you wake up in the morning? Do you have trouble falling asleep? Do you have a lot of nightmares? Are you waking up because you're in pain? And sometimes that is the answer. It's the person is not getting enough sleep for whatever reason, or not good enough sleep, not enough high quality sleep, and changing that can have a huge effect on fatigue. An important thing is looking at sleep apnea, looking
Mhm.
for sleep apnea, because people with connective tissue disorders are more likely to have problems with sleep apnea. And a lot of, doctors say like, oh, you don't fit the typical picture of someone who has
Right.
sleep apnea. You don't necessarily snore. You're not overweight. You're not an old man. Like it is not, they don't fit the clinical picture that you have in your mind, but we still find it more often. So that's something important to rule out. So that's a big factor. I always ask people what medications they're on, because a lot of medications have side effects that cause fatigue. As an example, antihistamines are a big one that a lot of people use for mast cell activation syndrome. In some people, they actually help treat fatigue because that help, part of the mast cell activation syndrome is causing that in the brain fog, and it can treat them. But especially at higher doses, that can contribute. Pain medications. I mean, the list goes on and on. There are a lot of medicines that fatigue is a side effect. And then, people who have dysautonomia, POTS, very often struggle with fatigue, and that can be directly related. The autonomic nervous system has a big role in sleep. So that's another thing we definitely talk about. Nutritional deficiencies, that's a big one also. Anemia, vitamin D, B12. There are a lot of different nutritional factors that can play into this diet. I mean, the list can go on and on. It's a complex issue, but there's a lot to think about, and there are really a lot of different ways for this person to get their energy back, and there are a lot of different solutions. What do you think? Are there other factors that you consider and talk about?
Yeah, no, I love all of that. And you're right. When people ask us questions, we usually come back with a lot of our own questions because those nuances matter a lot. So one thing I was going to add is, and you might have said this, but I was like already making some of my own notes. Beta blockers, right, are something that can be very, very effective for conditions like POTS. They can also be used for migraine headache, but they can also contribute to fatigue, and especially, kind of dose related. And it makes it so that you can't increase your heart rate with exercise, or almost impossible, if not impossible. So it makes it feel like you also have severe exercise intolerance, although for some people with POTS, it actually helps their exercise tolerance. So it's all in the selection of the drug and the dosing and those kind of things. So I wanted to add that as one other class of medication. And I also wanted to talk a little bit more with your experience with antihistamines. So we know that we have H1 antihistamines and H2 antihistamines. H2, we could talk about for like 1 minute and be done. Famotidine or Pepcid is like all we have, pretty much for the most part. We really don't have a lot of choices. But for H1 antihistamine, we have tons and tons and tons of choices, right? And we have the first generation that are not sedating. I'm sorry, we have the first generation that are sedating. We have the second generation that are, quote, non-sedating, but we know that that doesn't always hold true, right? So some people with the sedating antihistamines, they actually find them activating. So I have patients that take ketotifen in the morning because it wakes them up. Um, More often, it makes them sleepy, but it can wake people up. It can have that effect. And same thing with like diphenhydramine, which is Benadryl, right? That can actually make people more alert. Do you see that sometimes in your patients? If we talk first about the first generation antihistamines, H1 antihistamines?
Yeah, no, I definitely see that. It's interesting because for some people, I feel like that kind of paradoxical effect, when it has the opposite type of side effect that you would expect, or opposite effect, but particularly here we're talking about a side effect. I think for some people, it's like treating the underlying condition, like mast activation syndrome, that is contributing to their fatigue, and that's why they feel more alert and awake. And for some
Mm,
people, it seems more like it's a true like paradoxical effect. So I've heard stories from friends who tried giving their kids Benadryl on a flight so that they would sleep through the flight, and instead they were like
right.
bouncing into walls. Not in an EDS context, but just in general, there are people who have opposite reactions to medications, and then and I had just recently had a client who was tried hydroxyzine at night, thinking it would, because that's used for, calming and for sleep. And it made her super irritable. She was up the whole night. Like she could not fall asleep. It made her so irritated. So it's really interesting because another person that might have a positive like awakening effect, and for other people it is a negative effect. So even when that's why it's so nuanced, like you said, and it's so individualized because each person reacts to each medication differently. We're talking about antihistamines, but I think that's true across the board. And something I want to add before we move on is that you were talking about doses, and I think another key factor with fatigue particularly is the timing of medications. So I've had people who really struggled with taking an antihistamine in the morning, but if they take it at bedtime, it can help with their sleep and also with their symptoms. So sometimes just adjusting the timing of medications can be kind of a trick that can make a big difference.
Mhm, mhm. Yeah, definitely. I find that too with like melatonin. A lot of people, it, they might find it beneficial for their sleep, but either they're taking it too late. If you take it a little earlier because it's supposed to help prepare your brain for sleep, right? And then also sustained release can sometimes be more effective than regular because some people can fall asleep okay, but not stay asleep. So yeah, so before we get on to the next topic, I did have a couple of follow-ups with this. So one is when we're talking about antihistamines or any drug actually, and we're talking about effects and side effects. I've heard people also say that there's no such thing really as side effects. There's effects you like and effects you don't.
Yeah.
Which I think is a good way to put it. Um, I always wonder how much of that, if any, could possibly be due to excipients or the quote unquote inactive ingredients in medications. So we don't know what effects are from the medication itself and what effects might be due to the preservatives, dyes, fillers, coloring, etc.
Yeah, I think that plays a huge role, particularly people with mast cell activation syndrome. That is a big factor. I just had someone the other day who said that they were diagnosed with mast cell activation syndrome, but they can't take any antihistamines. All the ones they've tried make them feel worse. And I was looking through her history, and she has a severe dairy allergy. Well, Zyrtec contains lactose.
Mm,
And so perhaps that was setting off for severe dairy allergy and making her feel worse. And it wasn't actually the antihistamine itself; it was what is in it. A lot of people react to corn. A lot of people react to gluten. A lot more pills recently have been careful not to include gluten because that's a more common thing that people avoid. But that's definitely something. to consider for sure. I don't know why they make Benadryl like a hot pink pill because
Right,
a lot of people are sensitive to red dye, and it's like this is supposed to be treating allergies. Like, why are you
right.
introducing something that is totally unnecessary and very obvious? I always wonder about that, but I think something that people can consider, especially people who feel like they are allergic to every medication or they react badly to every medication, is having medications compounded. Oh, there are
Mhm,
special pharmacies called compounding pharmacies that will actually custom make medications. And it can be used also if someone has trouble swallowing pills, they can make it in a liquid form. If people are allergic to certain things or have, need it in a different dose that's not available, or there are some medications like ketotifen, which you mentioned earlier, which aren't available in the United States in an oral form. So that can be made up. You can't just go into a regular pharmacy and buy that, but you can get it at a compounding pharmacy. So that's something to consider. Unfortunately, insurance coverage of compounding medications depends on, it's much more difficult to get those covered if you have a clear, reason. Like, I have a severe dairy allergy. All commercially available preparations contain dairy. They will sometimes cover it, but it can be a challenge there.
mhm, mhm. Yeah, most definitely, and there are medications like LDN, low dose naltrexone, which I'm sure we're gonna talk about more later, that can be used topically, right? And it actually is absorbed just as well topically as orally. So, right, some people, their GI tract isn't working great, and so they might find something like that to be helpful. Oh, by the way, I should have said this at the very top of the session. This is not medical advice. We are sharing information and things that we have found helpful in working with patients and clients. And please always consult with your own healthcare practitioner before changing anything. This is not, we're not saying you should go do XYZ. We're just sharing some information here. Okay, so I wanted to also talk about aspirin. And when we're on this topic of like exhaustion, fatigue, MCAS, because we know that that can play a role as well. What has your experience been in aspirin and people with MCAS?
That's an interesting question. When you look at the official recommendations for prescribing for MCAS, there actually is kind of a stepwise approach that is recommended. Aspirin's a little further down the list, and it kind of has a for select cases only. So there's kind of a lot to be cautious of. Definitely not good for use in children. That's we don't use aspirin for people under 16. I believe is the cutoff in general. Um, and for people who have a lot of easy bruising or GI concerns, that may be something also that's not a good option for them. But for some people, it is really helpful. I've seen it seems, and I'm curious to hear what your experience has been. It seems like particularly for brain fog, I've heard a lot of people find that aspirin helps with that. I'm not sure. I'm not sure what the mechanism is, but that does seem to be interesting. It's definitely something that has helped people.
Right, right. I think it's in the blocking of the prostaglandins, and so yeah, so I find it to be helpful, and sometimes microdosing, right? So we're talking like start very low, go slow. I tell people to take an 81 milligram and try to break it into 4 pieces. Of course, baby aspirin is also do they even make that anymore? Given that like you said, because of Rye syndrome, right? We're not supposed to give it to kids, so maybe they don't even make baby aspirin is the 81 milligram, like, adult, preventative, treatment, which, by the way, the data is shifting on that also, but for, like, inflammation and stuff like that, it can be very helpful. Okay, so before we move on, I keep saying that, but I feel like there are some useful things for fatigue, and like you said, it totally depends on what's causing it, right? But do you have any favorite, uh, treatments or things like that that you have found, beneficial for fatigue?
Yeah, so I mean, I think it really depends on the underlying cause. It's hard
Mhm.
to generalize. I will say the most satisfying can be when someone has underlying sleep apnea that they didn't realize they have, because sleep apnea doesn't only affect fatigue. It can really have detrimental effects across the body, especially long term. And if people can treat that successfully, it can really be life changing. So I've seen that a few times where it's been like such a dramatic shift when people get treatment for that. So definitely treating that is a big thing. Um, and I know we said we'll talk about low-dose naltrexone, so here it is. That's something that people also have found to be really, really helpful for energy, and helping with that fatigue. Um, yeah, that's something that I feel like is a great medication to use when all of the kind of typical or our most common causes have been ruled out. And it's like, okay, people talk about like fatigue of chronic disease, like just it, it, no one can quite pin down what it is. Like we've tried to fix all the things that we know how to fix, and there's still this fatigue that's left. I feel like that's a really good place to use low-dose naltrexone because kind of whatever inflammatory type process is causing it, it seems to very often help.
Mhm, mhm. Yeah, definitely. I've seen a lot of really good results with low dose naltrexone, and if there is, an iron deficiency, that's obviously something that's super helpful. If there's, a B12 deficiency, even if the level is just kind of like borderline, I often find that really helpful, and I do in my clinical practice sometimes prescribe B12 injections, which, I know some people are like, "Oh, well, unless it's really bad," but no, I think that can be helpful. And the other thing that I wanted to mention was ubiquinol, which is the active ingredient in CoQ10. That can be helpful for a lot of people. And sometimes, I know that a lot of people get post-exertional malaise, so it's hard for them to push their energy envelope, but there are a lot of people for whom, a little more just getting a little bit more active, doing a little bit more can help, you know, their I don't know if it helps their mitochondria get more efficient or something, but, just slowly, increasing activity can be helpful for at least some people, not everybody, of course. Nothing works for everyone. I wish that was the case. And then the last thing I was gonna mention, of course, I live at altitude, so I think of this, like, more frequently probably, but oxygen, I think, can also be helpful in some people.
Yeah, definitely.
Okay, should we move on to the next question that we
Sure.
got? Okay, next question. Why does every medication I take for pain seem to make me feel worse instead of better?
Yeah, and that's such a tough question. I think also, unfortunately, one that we hear all too commonly. I think this is another one where we have to ask a lot of questions before we can give any answers. So, the what is this pain coming from? We need to identify the source of the pain and the type of the pain because to have effective pain treatment, it needs to match the problem that's going on. So, if you're having migraine headaches, it's very different than the treatment for abdominal pain. What type of, and if you're talking about headaches, what type of headache is it? The treatment is going to differ. If you're talking about abdominal pain, what is that pain coming from? Um, it could be so many things. So I think that is a huge first step is what is the pain? How are you treating it? And is that a match? Because so often people get put on pain medications and no one has taken the time to actually identify what the cause of the pain is. And I think especially in people who already have a chronic pain
Mm,
diagnosis label on their chart, a new pain is very often, unfortunately, treated as, oh, now they're coming in with a new pain. And that is so dangerous because, any new pain must be investigated, as if nothing else is going on. That is such a key. And I've seen, unfortunately, so many times people who have a new pain, either they dismiss it themselves. They say like, "Oh, now my whatever is hurting, it must just be another thing that's hurting me," and they don't get it checked out. They don't, they ignore it until it gets to the point where it's too bad, and it's like, "Why didn't you come in last week when this started?" Um,
right.
and of course from doctors who, see the chart and say like, "Oh gosh, this person's back again for something else that's hurting." So, I think that's really, really a challenge. Um, And I think also when we talk about we kind of alluded to this earlier with excipients and side effects or, intended effects, unintended effects, that, a lot of pain medications cause a lot of unintended effects. So sedation is a big one, like we just mentioned, fatigue, a lot can cause dizziness, GI upset. So sometimes the side effects, like the bad side effects, like kind of overshadow any benefit that the pain medication is providing. So if your pain is a drop less, but now you feel extraordinarily dizzy all the time, you're not even going to like register that your pain is a little bit less because you feel overall so much worse. So that's a big piece. And I think it's interesting because sometimes the effect of a medication, even if it's the effect that we want, sometimes it can make people worse. So we were talking just about this the other day that people are very often prescribed muscle relaxants, but in people with joint hypermobility, often the muscles are so tight because the joints are so unstable. So the muscles are really what's holding the whole body together because the joints are weak and they're unstable and the ligaments and tendons aren't doing their job. And so then when you relax the muscles, everything just can fall apart and it really is hard to get that back. And people really describe that it took me a long time to recover from that course from those muscle relaxants because it you have to build that up. And there are ways to relax muscles and build strength at the same time. But very often a medication that's given for pain, a doctor will say like, oh, well, you're tight all over. Let's see if relaxing it can help. Sometimes it can. Again, like Brady said, there aren't any always or nevers in this space. It's really so individualized to each person. But we do see that happen a lot, that it's just even if it is the intended effect of the medication to relax the muscles, that actually has a negative effect on the person's body. Um,
Mm.
and I think also talking about side effects, very often dysautonomia, people who have dysautonomia, that can amplify these side effects. So if you already have dizziness and you take a medication that causes dizziness, it can be so much worse than your average person. If you already have a lot of GI upset, you take a medication that causes GI upset, it can be that much worse. So kind of thinking about what people are already dealing with, and is this medication going to exaggerate those symptoms even more, trigger those symptoms even more?
Mhm, mhm. Yeah, I agree with all of that. I wanna come back to something that you said about, going in when you have a new pain. I totally agree. I'm sure you see this and you hear this like I do. I don't wanna go in for a new pain because I already get gaslit so much, and I see people saying, like, "I'm not gonna go to a doctor or an emergency room unless I'm, like, literally dying." And of course, that is just horrible. I mean, that's what the system has done to people. We have gaslit them so badly. I'm not sure what the correct wording is there, but we have done so much gaslighting to them that they would rather not get the care, not seek the care, not go in than experience that again. And I get it. I mean, I understand. You and I have heard from well, probably by now, like, tens of thousands of people. We've talked to tons of people, and so we know that this is not only super, super common, it is super detrimental to people psychologically, and we don't wanna put ourselves in that position again of being vulnerable, going to somebody, saying, "I'm experiencing this problem," and then them totally blowing it off. But at the same time, you're absolutely right. We don't wanna be writing everything off to, "Oh, that's just my EDS," because yeah, the whole, Hickdom's dictum, a person is entitled to as many diseases as they damn well please, and I think Dr. Knight earlier today during a recording said when he was talking about that, he said something about as many diseases as they want, and I meant to go back to that and be like, "It's not what they want, it's what they get." But anyway, um, so so for people listening, like, we totally get that it's really hard to do what we're saying. A lot of this is really hard, right? But at the same time, we just have seen bad things happen when people ignore symptoms. If it's abdominal pain and you can't really distinguish that this is different from your usual abdominal pain, but you actually have appendicitis or something, that's a very clear-cut example. Or you have some new tendon injury or whatever it might be. So yeah, that's tough.
And it's hard, and I really don't blame people, first of all, because they're afraid of what the reaction will be, and it costs a lot of money and a lot of energy and a lot of time that
Right.
you don't have to spend an entire day at a doctor's office, at an urgent care, in an emergency room, only to be told there's nothing wrong and this is just your whatever it is. This is your abdominal pain is just worse today than usual. This is just your, joint pain. It just happens to be worse in that shoulder. Maybe you picked up something too heavy. Like often, thankfully, it isn't appendicitis or cancer or, a fracture that you've been walking around with for a week. Those are all real examples that I've had from patients that they've ignored and then it turned out to be those things. Thankfully, usually that doesn't happen. Usually it's not something very serious, but and I like really empathize with people so much because you don't want to be that person that is like in the ER for every little tiny thing. But at the same time, it's really hard to distinguish like what is an emergency, what is
Right.
new? Is this just a flare of my regular symptoms or is this something new altogether? And honestly, like sometimes people ask me like, is this something new or is this just a flare? And I say, I don't know. Like you need to have imaging of your abdomen for us to know if this new pain is just a worse pain day today or if it's something new. Because we can't, there are clues, there are things that we can ask about and we can try to figure out like, does this sound like something new or is it just a worsening? But sometimes it really does take imaging or lab tests or something that needs to be worked up. And really, it is better safe than sorry. And we always want people to be able to get as much in an ideal world, everyone can get the care they need right when they need it, and it's with, no judgment and compassion and all of that. I know it's not so simple, but definitely ignoring new things can be really not a good idea. So,
Right, right. Before we leave the topic of medications, I also wanted to point out a couple of interesting things. One is tachyphylaxis and tolerance. So when somebody starts on a medication, like gabapentin is a classic example of tachyphylaxis, and gabapentin gets prescribed a ton for persistent pain. It can be very effective, but what happens is you take a dose and it works great the first time, but then you very, very quickly get used to it. So it really kind of loses its effectiveness, or at least it's much less effective. And I often give the story of when I took my very first dose of gabapentin, I was home alone. This is when my pain was so horrible, and I took 100 milligrams of gabapentin at bedtime. My husband was out of town, and either I called him or he called me. I can't remember, but I remember thinking like I might die in my sleep. Like I felt such a profound like I felt so out of it, and so like I felt so much of the effect of it with 100 milligrams. Fast forward when I had my spine surgery, however much later that was, a year plus later, I was taking about 3 grams a day, 3,000 milligrams a day, and could feel nothing from it really. I mean, I think I could have weaned off at that point and it would not have been any difference. But I just wanted to point that out. Tachyphylaxis and tolerance are real things, and they do limit the effectiveness of a lot of the medications that we might otherwise find beneficial. That's where pregabalin or Lyrica can be more effective because it doesn't have as much tachyphylaxis and and also rebound. So rebound or medication withdrawal type symptoms can also make a person think in some cases that the medication is doing more for them than it's actually doing, but their pain is getting worse because they don't have the medication in their system anymore. So, really figuring out if a medication is benefiting you is a little trickier than we would like it to be, don't you think?
and oh, definitely. And I think a huge part of the problem is that people with complex conditions are never treating one thing in isolation.
Right.
So it's like you're taking all these medications and you're trying to increase the dose of one and like, oh, well, someone suggested that I add this and do I wait until I increase the dose before I add it? Or, how long of a trial do I need for each thing to see if it's helping or not? And then in the meantime, you get the flu and it throws everything off. And, there are so many factors that play into all of this that, like, in an ideal world, we could just test each medication in isolation and not change any of the other variables like you could do in like a controlled, research study. But unfortunately, real life people are not a controlled experiment and it can be really, really tricky to figure out like, okay, is this the effect of the medication? Is it something else going on that's affecting it? And how do you kind of guide people through that? Because I find that's something that really is a challenge for a lot of people.
Yes, I love what you said. I wrote down what you said, never treating one thing in isolation. Yeah, that's exactly right. And what I tell people often is when you are polysymptomatic, so when you have lots and lots of symptoms, it is so much harder to make any kind of correlation, oh, I ate this or I did this and it made this worse. Or um, so if we can just try to like knock down some of those biggest symptoms, and you have to, right, take into account your individual day-to-day variability when you're assessing like is something helping or not. I mean, that's where journaling can be helpful. Journaling with the reporter, objective mindset as much as you possibly can. Because yes, it can be really, really tricky. It was only after I was feeling so much better that I could figure out, oh, if I do this, then this happens. But when you have like, 60 symptoms, you can't make a correlation and a connection. Oh, if I do this, then this happens because you're just sensing too many different things all at the same time.
Yeah, and I think often, people don't realize how much something is helping them until they try to stop it. So, I often tell people, like, talk to your doctor if, like, they're not sure if something is helping them. They've been taking a medication, they're not really sure if it's helping. Like, talk to your doctor, like, do you need to wean off of it or is it safe to do? Like, you always wanna make sure. But sometimes stopping it, it's like, "Oh, wow, that pain is back. I haven't had that pain in a long time." And sometimes you don't really realize it's really hard to, like, recognize absence of symptoms as
Yeah.
much as you feel them when they come back. So, it's like, "Oh, wow, I really am so much more tired now that I stopped that." Like, I didn't even realize, because there are very few medications that completely erase symptoms. They they can make them significantly better, but if it's still there, your body kind of adjusts to the new normal, and it's like, oh yeah, I still have that, but you don't realize how much dramatically better it is often until you stop the treatment that you're on. And it's like, oh, that was helping. Or sometimes it doesn't. And then you have a very good information. It's like, I feel exactly the same as when I was taking it. So that is probably not helping me. Obviously, again, again, disclaimer, some medications people need to take and it doesn't affect how they feel because it's working on something inside that is, like cholesterol medication. It's monitored by lab values. You're not gonna feel a difference if your cholesterol is higher or lower, but that's important to treat. So there are a lot of things that, across medicine that need, other testing. But for a lot of things, especially in, the when we're trying to treat pain, we're trying to treat fatigue, where it really is a very subjective measure of like how do I feel. And sometimes stopping it is the best way to see what the effect really is.
Mhm. Yeah, and I agree. It's a lot easier to notice when things are getting worse than when they're getting better.
Yeah. So just
For
like
sure.
how humans are wired, it's really interesting.
Yeah, that is so true for me, so true. Okay, let's move on to genetic testing. This is something that we have really been wanting to talk about. So you get this question all the time. I get this question all the time. Do I need genetic testing? And if so, what kind should I get?
Yes, this is a great question. Like I said, one that we get all the time. And I think it's really interesting because I kind of have a very interesting perspective on this. Because I started out my kind of foray into the EDS and HSD world in a genetics clinic. So
Mhm.
that is I was introduced from that perspective. Like, I work in a genetics clinic. These are the people we see. This is who we offer genetic testing to. And I didn't, well, part of it is that this was like 10 to, 10 to 7 years ago or whatever it is, that the time frame. But since then, the availability of do-it-yourself genetic testing, what's called direct to consumer, where you can go online, order a genetic test, they ship a kit to your door, you spit in a tube or swab your cheek or whatever it is, and then a few days later on the app or on the portal pops up all of your genetic results. I, I'm not sure how much that existed back then, and I wasn't aware of it because I was in a genetics clinic, or I know it's gotten more popular, but either way, it's kind of a very different perspective. So when we're talking about genetic testing for Ehlers-Danlos syndrome in particular, um, it's important to remember that the by far most common type of Ehlers-Danlos syndrome, which is hypermobile EDS, does not currently have a known genetic cause. So there is no genetic test. So you cannot get genetic testing for hypermobile EDS. If you read something online that tells you that they can do a genetic test that will tell you if you have hypermobile EDS, don't waste your money because that does not yet exist. Um, when genetic testing is appropriate for someone who has, suspected EDS, or HSD, which is hypermobility spectrum disorder, which are, very, very similar, kind of overlapping, um, is when there are what we call red flags or things in the person's personal or family history that are concerning for other disorders that we can do genetic testing for. So the other 12 types of Ehlers-Danlos syndrome we do have genetic tests for. There are other connective tissue disorders that have a lot of symptom overlap, like Marfan syndrome, Loeys-Dietz syndrome. It's a long list that we can test for. So if those things are present, then we definitely want to do the genetic testing to rule out those conditions and then go from there. And, when we talk about genetic testing, there are some providers who like to run genetic testing on everyone who has suspected EDS, just to make sure they don't miss anything. Which, as genetic testing is becoming so much more affordable and so much more common, that is one approach. And I think one thing to keep in mind is that genetic testing is not just like a lot of other lab tests. So if you want to know what your vitamin D level is, for example, you get a vitamin D test, they give you a number. Is it within the normal range? Is it within the range that you want? Yes or no, and that's it. It's not like open to great interpretation. With
Mhm.
genetic testing, it's much more complicated and much more nuanced than that, because the way genetic testing works is that they have what's called a reference sequence, which means it's the normal genetic sequence. That's what is normal. They compare the results of the person that they're testing to that. And a lot of the differences between people are just the normal variations that make us human, that make us different. It makes one, and they're benign. They're not disease causing. They're harmless differences. There are known differences that are disease causing. They're called pathogenic variants or mutation variants. And those we know are disease causing. But there are millions of variations or changes to the DNA that we don't know about. We don't have enough information to say whether they're disease causing or whether they're just benign variants and they don't cause any trouble. And those are called variants of unknown significance or variants of uncertain significance, VUS. And a lot of people, the more genes you test for, the more likely you are to come up with a VUS. And, the issue is if you don't have someone really knowledgeable interpreting those results or explaining those results to you, a lot of people get very worried and they don't understand what that means. And, a big issue with a lot of these direct-to-consumer tests are that it doesn't really make clear what types of variants they're showing. So
Mm.
I've had people say, like, I just tested positive for 4 different types of EDS and was like,
Yeah.
that's not, technically that is really not like that's never been reported. It would be not really possible, statistically, or you wouldn't, if you had 4 different types of EDS altogether, you would not be looking like you do now. Like it doesn't it really is confusing. So I think the biggest concern with increased genetic testing is that it kind of increases a lot of confusion into the picture. And for clinicians also, your average doctor doesn't know what to do with a lot of these genetic test results. So definitely there is a place for genetic testing. It can be very important to rule out conditions that we know are caused by genetic variants. But beyond that, it's really a really gray area. And as this is a constantly evolving area also. So the genetic testing is getting much better. There are labs that really do look legit out there, but the big issue is that if something is positive on one of those tests, very often, if you would take that to a geneticist, always, if you would take that to a geneticist, they will repeat the testing. So a lot of people just spend all that money on the test, and then in order for it to be, considered clinically significant for anyone to do anything about it, it would need to be repeated anyway. That's kind of what the landscape is right now. Sorry, that was a very long answer.
No, no, that was very important because the point about the direct to consumer testing and that the geneticist is gonna wanna repeat it anyway is a very important point, and I'm sure you've seen this too. On those reports, like you said, number 1, they don't use the 5 classifications that, are supposed to be used, right? Pathogenic, likely pathogenic, variant of uncertain significant, likely benign or benign. They don't use that, and also they overstate the the clarity of the results, in my opinion, in what I've seen. They overstate how much we know about things, and they really, I think, can be misleading, and people don't need more misleading things.
Yeah, I think it's really and people are it's such a tough line because if you have genetic testing results and it really looks like from the result, from this direct to consumer test, and looks like from the results that you have, I don't know, let's say myopathic Ehlers-Danlos syndrome. And then you go to your doctor and say, I had testing, it showed that I had myopathic Ehlers-Danlos syndrome. They look at you and say, you don't have a single symptom of that. You don't match the clinical profile at all. That doesn't make sense. And then it kind of like changes their view of everything that you're telling them. And unfortunately, I've seen that a lot, that people are bringing genetic testing results to their doctor, and the doctors really don't know about like what this means, but they know that it doesn't sound right for their patient, and that they kind of question everything else that they're telling them. So it's another unfortunate result of a lot of this, is that it's very unclear, and then it kind of muddles the whole picture even further.
Mhm. I love that you pointed that out, because I think another thing that, like, if I was a patient, I would not understand this, but as someone who has ordered genetic testing on numerous occasions, I understand it. That, if I was that patient, I would say, "Well, why doesn't my doctor just order a medical lab test for me to either confirm or not?" Whatever the form of EDS was that maybe was suggested on the direct to consumer test. But like you said, it's not the same as just like ordering a vitamin D level. You have to fill out like a lot of information, and it's time consuming for the clinician to order genetic testing. So it's costly for the patient. It's time consuming for us. And so if we think that the result is like, going to be negative anyway, it's so different from just like checking a couple boxes and giving someone a lab slip for a CBC, a CMP, and a vitamin D. It's just
No, for
it's
sure. It's not just another box that you can check off on a list of labs. It's a whole process to order genetic testing, right? And the reason is because genetic testing results need to be interpreted in context. So they
right.
ask on the genetic testing, they ask for the patient's history, they ask for the family history. In a lot of labs, you need to submit a pedigree, which is like the little pictures of the whole family history with it. It's important because the changes that they see in the DNA, the way they interpret them, how relevant they are, can change based on the actual patient. So, if someone comes back with a variant of unknown significance for, let's say, brittle cornea syndrome, and they don't have a single eye symptom, and they have perfect vision, and no one in their family has ever had any eye symptoms, it's pretty unlikely that they have brittle cornea syndrome, which can cause like corneal rupture in children and all sorts of things that are, you know, really significant. So as opposed to someone who's had multiple eye surgeries and multiple eye problems, and it's like, "Oh, wow, this fits them perfectly. We have
Right.
this variant, but this is much more likely to be significant for them than someone who doesn't match that picture at all." So it
Mhm.
really requires that interpretation, and I think that's a lot of what the direct to consumer labs are missing, is that they can do the test technically in the lab, but the they don't interpret the results the same way, and that's really the key in terms of how this changes things for the person. Because that's really the point of all of this, right? It's like, are we going to change the management based on what this is? Certain types of EDS require screening. You have to use more caution before you do a surgery or something. So it really is important. And you want to make sure that if those red flags are there, that people do have access to genetic testing. And at the same time, that people, even if they do choose to do the direct to consumer testing, if they're just interested, and now they have all these like nutrition panels and all these different panels that you can add, and like your Alzheimer's risk and all these different things that are interesting. But it's important for people to just kind of keep in mind the level of information that they're receiving and how significant it is to them.
Mhm, mhm. And when we meet next time, we are, because I'm cognizant of people's questions, I wanna make sure we get to that. And I have one more question that I want to address. The questions that you and I, got beforehand, we're gonna address those next time. And one of the things that we're gonna address next time that I know you and I have talked about that I think is really important is how you treat somebody who phenotypically looks like a different type of EDS, but they test negative for it. So we're gonna talk about that next time, because that is also very important. But I wanna make sure we get to people's live questions as well. So the next question I wanna ask you, and then we're gonna move on to people's, live questions. And by the way, if you've submitted a question live and we don't get to your live question, please either save that question for next time, and or you can submit it to us in advance before we do the next live, because that way we can make sure to have it as part of our prepared comments at the beginning. Okay, so why is EDS and HSD care so expensive?
Yeah, that's such a great question. I think the main reason is because complex conditions require a lot of time. Um, the system that we have now is not designed for people with complex conditions. I mean, you look at like the intake forms and there's space for like 4 medications, and so many people are like, past medical history. It's like I can't fit half of it on there. It's just not designed. Insurance reimbursements are not designed for long visits. Hospital, just everything is not set up for that type of care. So if you need a doctor who is going to spend more than a brief 15-minute appointment with you to focus on one problem and one problem only, you, you have to go outside very often, outside of the traditional system that's set up, at least in the United States. Every place in the world has different setup. But it's really tricky. I think, people who see people with these conditions, take a lot of time to prepare for the appointment. During the appointment, you spend a lot of time with the person. And then afterwards, I mean, I know after I meet with someone, very often they ask me a lot of questions. And I was like, that's a really good question. I'm going to look it up. I don't know. I've never heard of an association between some, random condition and EDS, but before I tell you, no, there isn't one, I don't know. So I'm going to spend time researching that. And that is all, part of the time. And I think that, you'll never see an EDS clinic. I mean, there aren't very many EDS clinics to see, unfortunately, but, they're not seeing 20, 40 patients a day like an average clinic often is. And I think that's really important. I know when I first started working as a PA, my first job, I was seeing like 40 patients a day and I hated it. It was exhausting. I never felt like I had a chance to really get the whole picture because by the time I started, and it wasn't it wasn't particularly complex patients. It was just an average, like caseload. By the time people would say like, oh, and I also have this, and I'd be like, oh my gosh, that changes the whole story, but I'm already late for the next person and I have to go. And now what? Because I can't even write my note because they've told me something that changes everything, but I'm out of time. It was so stressful. So when I started working with Dr. Francomano, I was like, oh, thank goodness, this is so much. Like I had the time to listen to people and to think through the whole story and to make sure that the answers that I'm giving actually consider everything that's going on. Because when you only treat a little piece of the puzzle, you're missing things and you can make things worse. So
Mhm.
that's what I think. I'd love to hear your thoughts as well.
Yeah, I mean, you can't see 40 people in a day with EDS and HSD and do them any kind of a service at all. You just can't. You can see, 1 an hour maybe. For me, I mean, my follow-ups are like 50 minutes long, and that is how much time is required, and exactly what you said. Yes, I am constantly researching things. So I'm spending time before the appointment, I'm spending time after the appointment, because you're right, people ask us great questions. People are so knowledgeable and educated, and they ask questions that are like, "Oh, wow, I never thought about that before. Let me look into it." And you can't do that if you have 6 other people waiting in rooms, and then your staff is coming to you in between with phone calls, you know, so and so called or wants their biopsy results or whatever it might be. Yeah, you just can't do a true service to people unless you are taking the time, and insurance companies don't value time. So I want to shift focus into some of these questions. There are some kind of like easy ones to tackle. So I'm gonna address the LDN questions first, and because I feel like there's a handful of LDN questions that are going to be easy to tackle. First of all, somebody asked, "What is LDN?" Low dose naltrexone. I'm sorry for using the acronym right away. So low dose naltrexone is a medication that naltrexone was originally developed for substance use disorder and alcohol alcohol and opioid use disorder, and we can use it in microdoses to stabilize mast cells, work on glial cells in the brain, which can help with central sensitization or sensitization of the nervous system, and that's a big contributor to pain. And it also can help with neuroinflammation and nerve pain, fatigue, as we mentioned at the very beginning of all of this. So it can be a really, really helpful tool. There's a bunch of LDN related questions, Rebecca. So I like copied and pasted this another document. So I'm gonna tackle some of these, but then feel free to weigh in. So somebody asked if it's taken at night or in the morning. I have to confess, um, when you're publishing a paper, like there's so many details. I was a co-author on a paper that went out earlier this week, or was it over the weekend? I can't remember. But anyway, on progress in mast cell activation syndrome over the last 6 years, and it has in the table LDN should be taken in the morning, and I was like, oh my gosh, no, usually at night. Um, I don't know if I didn't catch that or if I caught it and, kicked it back to the team for like an edit, and either it was, I don't know what happened. But anyway, um, LDN is usually taken at night. However, there are some people who like to take it in the morning because either they find that it disrupts their sleep more if they take it at night, or they have this really strong desire to still have like a glass of wine in the evening, and they find that they tolerate the low dose naltrexone better if they take it in the morning. So um, I prescribe it usually to take at night, but some people do take it in the morning. And I know one of the other questions was, do I recommend it twice a day, or is it patient dependent? I normally recommend people take it once a day, but some people do like to take it twice a day. I even have a physician patient who takes it 3 times a day. And I'm like, kind of defeats the purpose because you're supposed to block the opioid receptor for a few hours and then give the body time to, but she's like, this is what works for me. So I was like, okay, if that works for you. Like, you know, I don't mind giving people, when it comes to low-dose naltrexone, giving them the exact prescription that they want in most every case because it's so safe. And people figure out like where their best place is. Somebody asked, what is the range of doses? 1.5 to 6 milligrams is the usual dose for low-dose naltrexone. Let's see, we addressed this already. There were other LDN questions here. Oh, how long is the trial before increasing the dosage? Whoops. I usually ask people to give it a total of 6 months, but for increasing the dosage, like I usually increase it every week. I usually start at either zero point 0.5 or 1.5 milligrams and then increase by like one pill or whatever capsule every week, up to a maximum of like the 4.5 or 6. I also, though, have some patients who are they want to save money on the compounding pharmacy, so they will take the 50 milligrams from the pharmacy, break it into 4 pieces, and take 12.5 milligrams, and they say that works for them. I have other patients who take the 50 milligrams, dilute it in 50 mLs of water. Now you have your own solution of 1 milligram per ml. It's like all over the place. Okay, so that took care of that question, that LDN question. Let me see if there were any other. Do you have anything else to add while I'm looking to see if there were any other LDN questions?
Yeah, just about the dosing. I think you mentioned this, that some often people like to start at really, really low dose. Um,
Mhm.
and I think you mentioned earlier, like, start low, titrate slow. Some people in general with medications find that starting at, a quarter of the recommended dose, seeing how they tolerate it, and then kind of slowly increasing it, um, tends to work better for them.
Mhm. Yeah, it's really funny. At the beginning of COVID, because I knew that I knew that, LDN would help with, immune function, right? So at the beginning of COVID, I have to confess, I sent in prescriptions for a number of people for LDN that had not been on it before, and I was like, just to keep it simple, it's like, let's just take the 4.5 milligrams, and they did fine. They didn't have to do any titration. They were just like, no problem. So yeah, but our population is different. They generally tend to be very sensitive to things. So yeah, so that can be it varies so much. Somebody commented, I reacted severely even at zero point 0.1 milligrams daily, tried 3 different times. How do you determine if it's worth another shot? So what I always recommend to people, if they reacted adversely to any medication, and Rebecca brought up an excellent point about this at the very, very beginning when she was talking about lactose and Zyrtec or cetirizine. Find out what exact excipients were in those medications. Find out as much detail as you can, if there was a capsule, fillers, any of those kind of things. Get with the pharmacist, get with the compounding pharmacy, and try to get those details, because I find with a lot of people, if you figure out, "Oh, it was this excipient," then oftentimes they can tolerate it. Not everything, not everyone, nothing works for everyone, unfortunately, but, but that is something that I think can be very, very helpful, is figuring out your excipient reactions. Somebody did, let's see, was there any other questions about LDN? I think maybe that was all the questions about LDN. I just thought it'd be easier to kind of tackle those. We can take just a few more minutes here, but we will definitely do this again. Somebody did ask about tachyphylaxis, and thank you, Kate, for spelling that correctly. Yes,
That's one of those I always have to look up. It's like, "Oh, how do I spell that?"
that is how you spell tachyphylaxis. And we can talk about that more in the future if people want to. Okay. Um, because I want to get to this question about GLP-1s. Somebody asked about GLP-1s for people with gastritis, and I don't know if they meant gastritis or gastroparesis. But GLP-1 medications can be very, very helpful for inflammation, mast cell stabilization, micro dosed. I had a guest that I recorded an episode with yesterday, and he kept talking about losing weight, and I was like, "Not all patients with EDS need to lose weight, like, please don't say that." But anyway, uh, there are people that are normal weight or even underweight that I've prescribed GLP-1s for in micro doses. So, like, we're talking 1/10 the usual starting dose. So the usual starting dose of tirzepatide is 2.5 milligrams, and I usually start with 0.21 milligrams or sometimes even 0.14 milligrams. So like 1/10 the usual dose or lower, because so many people are so sensitive to these medications, and we want the lowest effective dose pretty much of anything, right? We want the lowest effective dose. So whether a person has gastroparesis or not, I have found that it can be well tolerated if we start low and we kind of address the gastroparesis as much as we can before we start. And if somebody has gastritis, we want to address that anyway. So do they need to be on an H2 blocker? Do they need to be on a PPI or proton pump inhibitor, et cetera? So those are things that we want to consider there. Do you have anything to add to that?
Are there particular ones that you find to be more effective than others, or do you start with tirzepatide as a kind of
Yeah, I really like tirzepatide. That's my favorite one. And I don't usually prescribe semaglutide. I usually prescribe tirzepatide most frequently. So okay, let's just see. I think we have a couple of this one's probably a pretty quick one. Is a mouth guard effective for sleep apnea, or are most people doing CPAP or BiPAP? Mouth guards are tricky because that can affect your jaw and that can make your TMD worse. So working with somebody who understands TMD and understands how to, because these devices that push your jaw forward can help your sleep apnea, but it might make your jaw worse. So you have to be very thoughtful about that. Do you have any thoughts? Oh, and plus the plastic can cause a mast cell reaction. So do you have any thoughts about that, Rebecca?
It's really funny that someone asked that because I was about to go into that and I stopped myself. I was like, "I'm talking way too long to this question." But that was something I was gonna mention, that be careful with the mouth guards because they can irritate people's jaw. I've heard that a lot from people. But they can be helpful for others. Again, like some things that work for some people, and it is something that works. So it's something to consider. Definitely be careful of the jaw. And like anything else, there for treating sleep apnea, there are a lot of different options. So there's different types of CPAP machines. There's different types of things. There are things like some people only have sleep apnea if they're lying on their back, so the positioning can help. So there are definitely a lot of different treatment options for that. Each with its own precautions, because not they're always things to take into consideration.
And that's a reason to be hopeful, because there's always new things that are coming out. There's a device called Excite OSA that you put in your mouth, and it like helps activate your tongue muscles. I know some people that have like gone to these programs where they work on the muscles in your jaw and your mouth and then do like a tongue tie, and it's helped their CCI or craniosacral instability, and it's helped their sleep apnea. So yeah, we're always coming up with, not usually me, other people. Other people are always coming up with new and exciting treatments. Okay, Somebody else asked about, well, they commented they recently discovered they were allergic to vitamin D because it's made from sheep's wool, and I have a lanolin allergy. So also an issue with something like Aquaphor. That's where CeraVe can be helpful because that does not have lanolin in it. Vegan vitamin D has been awesome. Is this common with MCAS, the sheep's wool allergy? I would imagine that it is, but do you know anything about that?
Not specifically, but, it's interesting because someone mentioned CeraVe that often has a lot of those have almond oil in it, so if you have a nut allergy, that can so I think a good takeaway is if something is bothering you, read the ingredients or find out the ingredients. Talk to a pharmacist, check the labels, because very often it's not the active ingredient in whatever it is that's what's bothering you, it's something else that's added to it, and you can sometimes find an alternative that will cause a reaction. And sometimes
Okay.
it is the active ingredient, so there are people who really have true penicillin allergies, and it is the penicillin that is, causing their reaction. So it's not always something else, but very often it is.
So when I changed there's a little toggle button to get to questions only. Are you okay to stay on for just a couple more minutes? Because I started at I started partway through when I hit that button for questions only. It eliminated a couple. Oh, that's because they didn't really ask it as a question. That's why. I bet it just looks for a question mark. So that's what happened. Okay, so I think we're good. Although somebody asked, but they didn't. So this is a note to everybody for next time. Make sure to put a question mark after your question, because otherwise, there's a button that you can push to toggle to questions only, and it doesn't recognize your question as a question if you don't have a question mark. Okay, so somebody asked, what are the benefits of LDN for dysautonomia? So I've seen a lot of people with dysautonomia benefit from LDN, whether it's through mast cell stabilization or helping with their fatigue. What have you seen with that?
Yeah, and it's interesting. I think this brings up a really important point is that so many of these conditions are so closely interconnected.
Mhm,
When you treat sleep, it can help with pain. It can help with dysautonomia. It can help with mast cell. If you treat mast cell, it can help with that whole cycle. If you treat the dysautonomia, it can help with that whole cycle. So very often an intervention into one area can make a big difference, ripple effect in
mhm.
areas that you wouldn't have necessarily expected. I think LDN is interesting because it's kind of one that targets a lot of different areas at once. So I've definitely had people report that they have, less dizziness, less fatigue, better sleep. I've also had people though that it's made them dizzy and that's why they had to stop it. So,
Right.
again, there isn't anything that's perfect, unfortunately, but definitely something that seems like it could have a big effect.
Mhm, mhm. Okay, last question. And thank you, Kate, for the kind comment. She called me the goat. Love her. I would not be alive and well today if not for her. Thank you so much. Okay, so last question. What would be a first course of action for a patient with intermittent small fiber neuropathy? So that's interesting because I thought small fiber neuropathy, like you have it or you don't. But anyway, that's how they asked the question. HEDS, possible idiopathic post a virus other than COVID.
So, with having that information, I would want to talk to that person and say which symptoms are most affecting your quality of life, because you've got a lot of complex things going on. Obviously, we could spend an hour talking to that person and getting all the details, but when you're asking the question of what intervention to try first or what symptom to target first, often the question really is which symptom is most affecting your quality of life. Like which if you had to pick one thing that you had a magic wand that you could make it disappear, what is that? And that's what we're going to try to target first because that usually has the most impact. And like I just mentioned before, sometimes improving one thing can make a big difference in a lot of other things. So if we try to hit the biggest thing first, then we kind of see, okay, once that's better, now what's left of the other things? And very often, if you're not sleeping because you have so much pain, if you treat the pain, your sleep is better, and then your energy is better, and then your appetite is better, and then you're eating better, and your GI problems are better. So very often it's like this ripple effect. So I
Mhm.
try to help a person identify what's the biggest symptom that's bothering you right now. And let's start there and then see what happens.
Yeah, love that. And that ripple effect that we see very, very often happens in both directions, right? That's how people end up so miserable because they have all these symptoms. Nobody's listening, nobody's paying attention, nobody's trying to help them. So they end up in this terrible place. But then likewise, it happens in the reverse. So some people get sick very quickly, but a lot of people get sicker and sicker over a more prolonged period of time. So oftentimes it does take a while to unravel all of that. Well, Rebecca, this has been a lot of fun. Thank you so much to everyone who joined us today and asked such terrific questions. Please send us more questions. As you know, I'm very active on Substack, and Rebecca is now on Substack also. So feel free to share your questions there. Feel free to hang on to those questions for next time. You could email them to me at info@bendybodies.org. Again, that's info@bendybodies.org. You could submit your questions there, and we will consider those for next time. And thank you so much again. I hope everybody has a good day, or as good as they possibly can be.
Good. Thank
Thanks,
you.
Rebecca.
Sure. Bye-bye.
Bye.